Came to Charlotte, North Carolina about 4 years ago after retiring from the Army. I've been an orthopedic surgeon for about 16, 17 years at this point. I'd finished my training in Charlotte, North Carolina at the old Miller Clinic before it became Ortho Carolina, and then served at Walter Reed in multiple capacities, including program director, as well as the chief of orthopedic surgery. And then after retiring, after 21 years in the military, returned to where I did fellowship, and I am part of the fellowship faculty at Ortho Carolina at this time. Any comments, Lisa? Can everyone hear me well?
You sound good to me.
Okay. I'm just trying to see if I can move this here now. Just as disclosures, I do work with Crossroads Extremity Systems in product development and consulting, and there's an honorarium and some content for this has been provided by Crossroads Extremity Systems. Getting into one of the most common procedures that I perform at this time, that is a MTP or metatarsophalangeal arthrodesis. Some of the indications that are commonly found for this include hallux rigidus, go ahead, which is essentially arthritis in the big toe joint. Severe hallux valgus, typically it's either recalcitrant hallux valgus, somebody that has been treated with a bunionectomy previously, or has hallux valgus with degenerative changes, inflammatory arthritis, post-traumatic arthritis, or a salvage procedure in some situations such as severe trauma, extremity projectile wounds such as bullet wounds and those type of things. Goals are primarily with this pain relief as well as correction of the deformity. As with many procedures that we perform in orthopedic surgery, AO principles apply to this as well as those. We want to preserve the blood supply. We want to provide appropriate alignment or reduction. We want to provide rigid fixation and early mobility, so allowing the patient to get up as soon as possible. So when we prepare the joints for a Hallux MP fusion, we need to expose the subchondral bone while minimizing bone removal or shortening. This is important that we at least penetrate that subchondral bone, as the subchondral bone itself is a block to fusion, and we need to get the blood supply from the cancellous bone underlying that for the fusion site. Some of the different options that we have is the mechanical or mechanized debridement, such as the cup and cone reamers that are found in many sets nowadays, that has become popularized over the last 18 years or so. Flat cut resection with a saw is another possibility, as well as manual debridement. When we look at this, the cup and cone debridement really has become the workhorse for most Hallux MP fusions. It allows you to move the toe around into different positions, so you can dial in that final position that you want, and also provides potentially an excellent surface for healing. Some of the disadvantages, however, include that you can be overly aggressive with your reaming. I think everyone's had that case where you're reaming either the proximal phalanx or the distal metatarsal, and the reamer penetrates through the subchondral bone very quickly, and you end up with a defect. There are some things that can be done to avoid that, but it can potentially be catastrophic. Also, doesn't work with all anatomy. Sometimes, especially in revision cases, we're going to stay with flat cuts. And sometimes with prior surgery, the joint is so scarred in that you cannot get adequate exposure in order to perform a cup and cone type joint preparation. Again, other possibilities are flat cuts. When I was a fellow, we did more flat cut type exposures. It is easier if you're doing a bone block or a distraction arthrodesis, but you can't really adjust the position without recutting, and you do globally have less surface area for healings. And you do have to watch and not shorten that metatarsal overly, because you can't have transfer metatarsalgia to the lesser metatarsals following this. And then lastly, manual debridement. Again, I rely on this for those patients that have very stiff Hallux MTP joints that may have had prior surgery, and prepare the joint in this fashion, removing the cartilage, penetrating the subchondral bone, and you do end up with somewhat of a cup and cone type of residual bone in order to fit the toe and align the toe however you want. One of the techniques that I do use that is a throwback to when I was a fellow is penetrating that proximal phalanx in the center and really making sure that you're down through and into that cancellous bone. One of the important factors when we're performing this surgery is position. You do want to have slight valgus and slight dorsiflexion. In the next frame, you can see that we're using a top plate from one of the sets in order to adjust and determine how much dorsiflexion the hallux has. I typically like to have about 3/16 of an inch at the IP joint underneath in order to avoid plantar flexion of the hallux. I have had to come back and do osteotomies or a slight wedge osteotomy if that phalanx is too plantar flexed and they get irritation under the IP joint. You also want to confirm the alignment radiographically. You can see in this area right here that this toe is pinned, and that's a good way of holding this toe in position as we go further on in the surgery, and we'll discuss that in a little bit. One of the workhorses that has become very popular in the last 15 to 20 years is we've gone more to dorsal plates and, again, lag screws instead of cross screws has been the lag screw. You do have to insert it at an angle. I typically go from distal medial to proximal lateral, although I have done crossed lag screws, even going from the lateral portion of the proximal phalanx and coming into the metatarsal head that way if needed. You do have to avoid the plate screws. And what are the representation that we have here with the quarter is really how much compression you get with that lag screw. And so what the lag screw does is, again, it prevents the plate from essentially bending dorsally and getting some gapping plantarly, but it is a small area that it is applied to. Again, the work of the lag screw, you do need to be careful as far as measurement, but probably more careful as far as not having to drill multiple times, as you really only get about one shot once you have drilled this in order to place it. You do need to make sure that the screw threads are passing through the cortex and that you do not penetrate the distal medial phalanx or fracture the phalanx. Headless versus headed screws have been looked at. Again, a headed screw can be more prominent, but it is, in my opinion, easier to place. A headless screw, while it is less prominent, you do have to watch it and make sure that you don't go through the cortex, because you start to lose purchase at that point when the headed portion or that threaded portion on the head goes through the cortex. Another option that you have is compression plating. It does eliminate the fiddling with the lag screw, but we'll talk about this a little bit later. It is not as strong as having a plate and a lag screw. And then compressing dorsally can cause gapping and dorsiflexion of the toe. One of the things that you have to watch for. Many times, if you're using this technique, you will place the lag screw first in order to prevent dorsiflexion of the toe as you compress with the plate. You do have to guess somewhat how much to overly flex the plate and contour it in order to get that plantar compression without, again, gapping during the compression cycle in the plate. In summary, for this, position is critical. The relative surface area for this fusion is small. Lag screws and compression plating can be tricky. And compressive lag screw is not necessarily the ideal means by which to get compression through your fusion. And that's why we're here talking about this today. Some of the data, when you look at dorsal plates, lag screws versus cross screws, in the study by Bernowski, they looked at 12 matched pairs of fresh frozen cadaver specimens looking at plate with lag screw versus cross screws. They did use cup and cone reamers in that study, and then they tested their construct to failure. The plate and lag screw construct was statistically stiffer and had a greater point of the ultimate failure. In another study by Clausen and Ploss, they looked at retrospectively different fixation methods. They were ideally looking at this locking plate with a lag screw versus a non-locking plate with a lag screw versus lock screws. And when they looked at this, they had 60 patients, 20 patients in each group. They did have 4 non-unions in the cross screw group and only one dorsal plate non-union or one non-union in the dorsal plate and lag screw in each of those groups. And so they concluded that the dorsal plating with lag screw provided reliable fixation. Other data, again, looking at plate versus screw fixation, 72 patients, 1 oblique screw versus 2 crossed lag screws in a plate. And then again, a plate augmented with the plantar lag screw, and the plate was significantly better than screw fixation, but not enough power to tell between just the plate and the plate and lag screw. Looking at Harris and Moroni, biomechanical comparison, 4 techniques, plate in all 4 groups. They just had different joint preparation and then a single screw versus the cross screws. What they found that a flat cut versus a cup and comb didn't matter statistically in the end as far as stability of the construct, but the strongest construct was a cup and cone with plate and crossed screws, and the weakest was the dorsal plate alone. As we come into this and we're talking about compression with staples, one of the things that you do have to realize is that once you get that compression and you're using a plate or screw construct, that is the greatest compression that you're going to get. And you lose compression from that time out. And that's why I've included this paper by Garris. It's a Lapidus fixation, so it's not an MTP fixation, but what they were looking at, I think, is important. And what that is that you start losing compression almost immediately. So when they looked at the plate alone versus the plate and the lag screw, a plate alone, and this is a compression plate, had lost complete compression, or it had 0 compression after 46 minutes and had 50% loss of compression in only 5 minutes. When you look at the plate and lag screw, it did last longer. So it lasted about 5.5 hours, but you had 50% loss of that compression within just 50 minutes. And so and this is standard for any compressive device except for something that is flexible that is going to provide continued compression. And so that's why we're looking at Nitinol Staples in this case. And so in this evaluation by Hoon, biomechanical evaluation of Nitinol Staples, the staples were compared to bridge or compression plate. Staple fixation showed increased compression and contact area maintenance. And so the staple fixation was stiffer at higher loads to reach a 2 millimeter gap formation, and the double staple was the best fixation for preventing gap. But staples alone didn't, and this is an important aspect to this, did not prevent deformities in other planes of deformation. And that is like your translation, your right to left shifting, or your torsional. And we'll get into this a little bit later as we go through some of the information on this technique. So this is a dynamic construct versus a static construct. And what we're looking at here is a plate with a lag screw. And that's ice that's melting there. And what you can see is that after the ice melted, the gap sustained. So what they had done, and I'll run this again, is they had put the plate and the screw construct with the two blocks together. They then caused a force to go across and caused that gap to occur, and then placed water in there and froze it, and looking at what would happen when you then allowed it to thaw. And so what you can see with this, and hopefully this comes back again, is that as it thaws, that gap does not close down. While you have stiffness with the plate as well as the screw construct, if you have any gapping, and gapping can occur not only from deformation, but it can occur from osteolysis. As the two bones are pushed together, some of the bone is resorbed, and you are not going to get compression across that with this technique. So this is an obligatory slide, but no one wants to see the gap. And so we don't want to see a gap when we're trying to get two bones to fuse. And you can see in this lower area here, there's a gap between the phalanx and the distal metatarsal. So with a staple, you have continuous plantar compression. So you do not need a lag screw with the staple because it is compressing across the plantar aspect as well as the middle aspect of your fusion site. And so that's discussing Nitinol. It was a nickel titanium Naval Ordnance Laboratory essentially product back in the late 50s, and it's 50% nickel and 50% titanium. It is used throughout the body. One of the companies that I've discussed Nitinol with has been one of the primary companies that's used this in cardiac stents as well as in DVT prevention type products. It's also used in orthodontic wires, and then we're here because it's also becoming widely used in musculoskeletal implants. And so why is that the case? And it's because it has continuous compression. When you insert it, you've stretched the metal, and that it is trying to always return to its original state, and that provides that continuous compression. So staples lack the rotational stability and length of a plate, and many surgeons are hesitant to try the staples with anything other than an Aiken or a phalanx osteotomy at this point. This is one of the first areas that I used the plate and staple construct in was an MTP fusion. It's one of the ones that made the most sense to me to go ahead and try this out in, and I've been very happy with this. Plates have the security of what we're used to, so they provide rotation and medial lateral stability, and the staple gives us this continued compression. So even though we compress and then we get a little bit of osteolysis at that fusion site, the staple continues to compress following that. So this is a video, and it's again similar preparation where the plate and the staple were placed. Force was placed again to cause a gap to occur, and then water was introduced and it was frozen in that position. But what you'll see is a much different kind of evolution here, and that's just telling you or showing you on shadow where the staple would be in this construct. So as you are watching this and the ice is melting, you'll see what happens, and it's primarily because of the Nitinol staple in this construct. And so you have loss of that gap formation. I'm just going to play this for you one more time. So as soon as it runs to the end. So again, gap was formed, and this is the gap was formed after the plate and staple was placed. It was then frozen in that position, and this gives us a time-lapse, essentially, way to see what happens with this. And as that ice melts and goes away, your gap is decreased. What's interesting is also to see what happens in the plate. And so just watch real closely on the top left side of the plate what happens with this as this ice melts and goes away. You can see that it moves just the slightest amount and allows that upper gap to also disappear. And so this is a close-up looking at that. And this is a non-lock screw that's in that plate at that area. And you can see the plate move just the slightest amount. It's about 3/4 of a millimeter that plate moved with that as the staple compressed. So one of the things that I wanted to look at this, and this is one of the slides that Crossroads was able to make available for me. And this is, looking at torsion. So this is just one of the deforming forces that can come across the MP joint. The other is angular deformity as well as dorsal plantar subluxation. But one of the things I wanted to highlight was why use a staple and plate construct? Why not just use two staples? And the reason is that the staple and plate provides tremendously more stability. So when you look across here, the staples that are typically used in this plating system are your Hymax. They are coming out with some newer staples in the future, but you see that these do not provide, even two staples don't provide great torsional control. Plate, and then some of the other competitor staples, claw plate, and then when you look at it, these are the two that have the highest torsional control. And the plate that we're currently using for Hallux MTP fusion has 2 screws proximally and 2 screws distally most of the time, unless you're utilizing a revision plate. And so the torsional control would be close to what this Z plate provides. And it's just absolutely fantastic to have that much stability in addition to the compression. So when you talk about order of MTP fusion, all of you have done many of these. You're going to prepare your joint however you feel the most comfortable. Position the hallux, again, very slight valgus, slight amount of dorsiflexion. Again, I look at the IP joint. I want to get about 3/16 to 1/4 of an inch underneath that flat plate that I'm holding at the IP joint, and then I fix this. It's great because I put the staple, or excuse me, I put the plate on top of the Hallux MP joint. Now, one other thing you always want to do is take the dorsal osteophytes off of that distal metatarsal. If you don't take those off and you start fixing the plate, you will dorsiflex the phalanx. So make sure that that is a flat area there. And then I usually fix the plate in place with a couple of olive wires. And the holes are offset such that you can set the olive wires to the side and then place your staple in there. And then I usually do 2 distal lock screws in the phalanx and then 2 proximal non-locking screws. And this just goes much quicker for me than putting a plate in place, utilizing a lag screw, trying to avoid the lag screw while I'm putting the other screws in. And then also getting compression and trying to avoid dorsiflexion the phalanx at the same time. Again, my personal recommendation is to use non-locking screws proximally. So staple plates, you can see immediate compression is evident on the first lateral x-ray. What you see is slight leg convergence. That's what that's terming, is where the legs are coming together a small amount. And that is the compression that you're seeing. The joint fusion site will automatically be stable at that time. Then you can start putting in your screws. Again, resorption or osteolysis at the fusion site is compensated by the Nitinol Staples for gap recovery, and it's been fast, easy, and reproducible for me. So just looking at some different case studies here, 65-year-old female, rheumatoid arthritis and osteoporosis, 30-pack year history of smoking, and then also, as you can tell, previous foot surgery. And this is a common deformity that we see. So standard technique, cup and comb reamers. This is the standard plate. This is not a special plate with an 18 millimeter staple that's placed, and you can see at 6 weeks You can see that no gap is seen at the fusion site on either the APOs or the lateral X-ray. Looking at a CT scan at 2 months, you can see that the fusion site is completely solid. There is no gapping across that area, and there's no fibrous tissue that you would see. It's all grown in with bone, excellent across that area. So this is a 2-month confirmed CT fusion in an osteoporotic rheumatoid patient that was a smoker with prior surgical history. This is another case where we're looking at is a non-union of a previous MTP fusion. Unfortunately, with this one, due to the motion across this area, there was some bone loss, and in order to get back to good bone, flat cuts were necessary. This is an allograft bone block, typically a tricortical iliac crest allograft that is in there. You can see that this plate is a little bit longer and that there are 3 screws proximal in this plate. That's the reconstruction plate. But these are the radiographs demonstrating excellent compression across that area. And this is a CT scan showing healing across both areas at 10 weeks, which is rather outstanding when you're dealing with an allograft distraction arthrodesis, trying to get 2 sites to fuse. So in summary, we feel that this is biomechanically superior. You use the classic dorsal approach, but because of the legs of the staple, you have a plantar tension band. It's simple, easy to put in, no lag screws or compression plating are required, and is rapid, meaning it saves you time in the operating room. And so having this staple in place is like being able to retighten the lag screw at every step until healing occurs. So, as with anything, there's certain indications and risks, and this is obligatory that we give you this information. But this is a plate and staple construct for the Hallux MTP joint. At this time, I'd like to entertain any questions, and I'll be looking at the questions coming through. From one of the questions is, do you ever lose alignment of the toe after putting in the staple and before you put in the screw? So I typically keep the cross wire that I've had in place until the distal screws are placed. Every once in a while, I'll have to put distal screws first and then a proximal screw and then pull the wire at that point. But I have not had that problem with losing a reduction after placing the staple. Sorry. And then one of the participants asked, what is my post-op protocol? I do let my patients weight bear on their heel immediately in a post-op shoe. When they come back at 2 weeks, sutures are removed. We get radiographs at that time, and I typically would allow them to weight bear as tolerated in the post-op shoe until 8 weeks. And as long as everything looks good at 8 weeks and I have a solid fusion, then I'll let them come out of the shoe at that point. Many times, because of swelling, they may not be coming out of the shoe at 8 weeks. They may stay in it a little longer just because they may have a little bit of swelling. Another question was, what was it that we said that may cause gapping if you're not careful? I think that was probably back looking at the dorsal plate by itself. If you don't bend the plate slightly, this is just like on a humerus fracture. You have to pre-bend the plate, give it a slight curve to it in order to prevent gapping on the other side as you compress. And so if you don't pre-bend the plate slightly, what will happen as you compress dorsally is you'll gap at the bottom. Another question is, when do we use locking versus non-locking screws? Again, I classically always use locking screws in the phalanx, and then I use non-locking screws proximally. If I had somebody with very, very poor bone, I may consider locking screws proximally, but I want that staple to be able to move the plate slightly. When you're doing your non-locking screws proximally, I am not as worried, especially with that most proximal screw, about going through the plantar cortex and making sure that I have good purchase in that plantar cortex. So I will keep it 2 millimeters longer than it measures sometimes to make sure that I get good purchase in that plantar cortex for the proximal screws that are on the metatarsal. I have another question is, what needs to be done if there is a gap after putting in the staple? I think that if you have a gap after putting in the staple, it's because the joint was spread apart at the time that you put the staple in. And so you really just have to make sure that when you're putting in that wire, that there's good compression across the fusion site as you're putting that wire in. And typically you do have pretty good compression across it as you're compressing that toe and holding it in position, and usually then having somebody else fire that wire across the joint, or you're at the end of the bed if you're by yourself holding that toe in position and you're really compressing. And I have not seen that be a problem, that you have a gap after putting in the staple. And so another question is, what is the biggest advantage of the staple versus a lag screw? And the biggest advantage is really twofold for me. One is, if I'm putting in a lag screw, I don't have to avoid, with the staple, I don't have to avoid the other screws in the plate. So with a lag screw, I've got to make my trajectory such that I'm avoiding the other screws that are in the plate. The other advantage is the lag screw is static. So once you put it in and compress, that is the most compression that you'll have. You just start losing compression from that moment on. The other part is with a lag screw, if they walk on this and they get a little bit of plantar gapping, it is not going to recover from that. If they pull that screw slightly, or if the head pulls through the bone, they will not recover. Whereas with the staple construct, it is constantly compressing and making up for that. Let's see here. Another question is, in what order do I place the screws? I put the staple in first, and then I do my distal locking screws, and then I do my proximal non-locking screws. And then another question is there any concern about mixed metals with the nickel titanium staple contacting the titanium plate? We have not seen any problems with what's termed galvanic corrosion. I think that these are probably electrically, as far as that, I can't remember the technical term for it. It's been about 25 years since I was in inorganic chemistry. But there's the different charges that metals have, and you can have galvanic corrosion, and we have not seen that with this. They did have some problems in some of the hip implants over the last 5 to 10 years, as they were trying to mix metals that were very, very different, and did see some of those problems. So another question is, how do I throw my K-wire for initial fixation? So I usually go from distal medial, so at the base of the medial proximal phalanx, and cross the metatarsal head, and then come out the lateral cortex of the metatarsal itself. I will, in some cases, especially in deformity cases, so if somebody that comes in has a hallux valgus angle with pronation, but a hallux valgus angle of like 50 degrees and 30 degrees of pronation, after you've done your cup and comb reamers, you prepared your fusion site, and you reduce your toe, you put that first wire in, I sometimes will take a second wire and put it in from the first interspace, so on the lateral cortex of that proximal phalanx, and do crossed wires before I put on the plate and the staple. And what I really find is that provides just a little extra stability as I'm putting everything on, especially when you have that pronated toe that you're trying to correct. Because one wire, it can sometimes spin around the wire, and just putting in that second wire can really help. Any other questions? Anything that I can help you out with? This has become my go-to for Hallux MP fusions. I've had, again, a lot of success with this. And again, probably the biggest thing is I'm not worried about the osteolysis and gap formation. But the other thing that's really helped me is it's probably 10 to 12 minutes faster in the operating room, placing this plate system versus the other plate systems that I've used.